Okay. Hello, Hamish.
Hello, how's it going?
Good, thank you.
Excellent, thank you.
Are you on my petitions committee? Yes.
I pop up all over the place. Thank you.
Hello, thank you.
There you go.
Thank you.
All right, we have you here for 10 minutes.
Did you say 14? Because I'd like to take those extra 4 if I could.
10 minutes, 10 minutes, but can always be generous if it's going well. No, it's good. I won't talk anymore. I'll hand it over to you. Welcome to the Health Committee for talking on this very important matter. I'll hand that time to you now. Thank you.
Thank you. Good morning, everyone. My name is Bronda Smith. We've got Nikki Bazant beside me, my heavy hitter, and also Sola Freeman, who's come in to support. We're here to talk to you today about menopause and the health impact that has for women in midlife. Mine's a personal story. I've come from someone who had to leave work, almost lost my marriage, almost was considering what my life might be if I wasn't here. So it has a fundamental impact on my life. When I left work, I had to spend 6 months putting myself back together. It was a pretty tough time, and I was lucky in the fact that my GP said to me, I don't know enough anymore, I can't help you anymore. And I had to go and pay $300 to see a GP menopause specialist, who basically, with a therapist, put me back together. And mine isn't an uncommon story. I am actually part of a menopause support group. I'm one of the administrators. There's 17,000 members of that, which is in Menopause Support New Zealand on Facebook. And my story is quite common, which is really disconcerting for women in their 40s, 50s, are in a space where they've quite often hit the C-suite. They've become a chief executive or an executive of some sort, and they're in that space where they actually become almost non-productive. And really, for me, that's preventable. And as Nikki says to me, prevention is not sexy. We'd like to make it sexy because I think it has such long-term ramifications on the health system. And that's what Nikki's going to talk to us around the ramifications on the health system, that it's a preventable process. And, the low-hanging fruit that we're going to talk about today, and it's not a lot of money, stops a lot of issues down the track. And so I think that's where, if the Health Select Committee can look at the prevention side of what we're trying to achieve, then the aged care costs of women on later life, plus the ability to continue to work, continue to be a productive member of society, stay married, all of those things is really important. So I'm going to hand over to Nikki because she's going to give you some stats and figures. Nikki's a journalist in the science space and has written 2 books on menopause or midlife. So I'll let you, and then I'm going to finish off at the end. So.
Okay, so we're asking you to consider a couple of things which we've outlined in the paper that we've just given you. Investing in funding for menopause education for GPs, and midlife health checks, and a menopause info pack for women. So menopause te ruahinitanga is a whole body and mind transition, and 100% of people with ovaries is going to go through it. So that includes trans and non-binary people, but mostly it's women. Whether or not they have symptoms, menopause is going to affect all of those women's health. So we need support through the menopause transition, and we need consistency of care. And it's really important to understand the impact of not having that. Most women are going to live a third or a half of their life in a postmenopausal state, and menopause has significant impacts on our whole health as we age. It's not just about reproductive health. So it's emerging that midlife is a critical health window for women. And there are some examples which I've detailed in this report. One is bone health. So 1 in 3 women is going to suffer an osteoporosis fracture, which I'm sure you know, costs the health system hundreds of millions of dollars, and is responsible for 190,000 hospital beds days annually. There's a lot that we can do to prevent that with lifestyle and other health interventions, and that includes menopausal hormone therapy in midlife. Heart health is another area. Heart disease is the #1 killer of women. Currently around 1 in 8 health dollars, again, I'm sure you know this, is spent on heart disease and stroke. And it's preventable again with intervention at midlife. And there's a hormonal component there as well. Women are twice as likely as men to suffer from dementia. And that's growing, as you know, and estimated to cost the health system, close to $6 billion by 2050. The changes that are the precursors to dementia start to happen inside the brain decades before they become evident, and that is in midlife. And it's emerging in the evidence again here that there are things we can do in midlife to lower the risk of developing dementia down the track as well. So a health check and interventions, if they're needed, in midlife aimed at prevention is going to pay off later on in better health for those women, better quality of life, better earnings, better retirements, and less burden on the health system and the economy later. It's going to make those women's lives better, and it's going to save the health system money. The average age of a GP in New Zealand is 53, and most of those GPs didn't get any education on menopause. It's not their fault, it's just how it is. But if they have that education now, they've had to seek it out. And so there's a gap there. There's inconsistency amongst the care that women get when they show up at their GP needing help. So we need that funding for GP education, and we need that midlife health check or PAC. It could be modelled on what's going on in Australia. There's a midlife health check there. If we intervene now and identify the issues now, we can empower women with the tools that we need to live a vibrant and healthy second half of our life. And thinking a bigger picture, we have a gender pay gap, we have a retirement savings gap, and we can't dismiss the impact that menopause has on those things as well. Not being supported through this life stage can impact that. Our generation is going to be living longer and working longer than any before us. And so we're urging you today to consider this as an investment in women's futures and their health. Kia ora.
Thank you very much. Yeah. I'll open it up to members.
Sorry, I've just got one last little bit to say. There is on the back page of the handout a quote that I've taken out of the support group, which was posted last week. And it's about a lady who had been asking for hormone replacement therapy, or HT, for 2 years. She lifted a box and fractured her back. And it's turned out that she's got osteoporosis. Now, those 2 years of not being on HRT has probably created a lifetime for her now of issues. My mum has got osteoporosis. I've been very fortunate that I've known about that, so I've gone and got some bone density scans to have a baseline. But that's just one story. The inconsistencies that comes through in their support group of GPs not understanding what hormone replacement is, not thinking that hot flushes is the only symptom that you have, not understanding that it happens before your 50s. These people of, 45 to 55 is the average onset of perimenopause. So that inconsistency is something that we just, we really need to help doctors understand and give them the education that they need and the support to women and the knowledge to women so that they can also advocate for their own health outcomes. And that's it. Thank you.
Thank you. Dr. Vera.
Thank you so much for this really important submission. I recall when we consulted on the women's health strategy, a very common experience of women feeling not heard in the health system for a variety of reasons, and menopause would be one where I note your concerns about are widely shared about not having symptoms taken seriously. I want to ask you about another point you made about economic participation. It's also well documented and the subject of a report by the New Zealand Institute of Economists showing the massive productivity loss to the country because we're not using midlife women's skills as well as we could be. Can you help me understand what you'd like done about about that problem. How could workforces keep skilled midlife women in employment better, and also be accommodating of them when they run into situations where their employment's interrupted?
Yeah, so as part of the petition, I had 3 aspects to that. One was about workplace understanding and policies. My nirvana in that space is that MB provide policies and education to businesses for them to be able to understand. And there's a lot of, and we're getting off topic here a little bit, knowing that this is the Health Select Committee, but there's quite a few companies that are doing that already, but they're the bigger companies, the IAGs, the ANZs of the world. And that's not where most of our employment is in New Zealand. It's the smaller companies, the 15 employees, the SMEs that are the ones that probably can't get to that. I asked, as part of mine, I asked for a 9-day fortnight. That was declined. I really wanted that one day just to be able to sleep in the morning because my sleep was awful. And I think that understanding of how significant the effects can be for employers is really important.
Carlos?
Yes. Thank you for your submission. I think this is one of the very important topics. Based on your understanding, what is the difference between New Zealand, the strategies-wise, or the way we approach this transition period compared to the rest of the world?
Well, I can answer that. So Australia in particular is leading the way, and I think I know we have probably a bit of chip on our shoulder about Australia, and we probably need to just step up a little bit here. So in particular, the Health Select Committee, they had a Senate inquiry, and that created about over $700,000 going into women's midlife health. They've just identified that they are going to put aside specific doctor's appointments each year for women that are geared specifically towards menopause. Now, when it comes to the workplace situation, yes, workplaces need to do something, but actually it's the health of women that's the key issue. If women's health is identified and sorted and looked after, then their ability to be in the workplace is going to be that much better. Does that make sense? So in the sense that the UK is doing better, Australia's doing better. A lot of this is low-hanging fruit. It is not hard for us to catch up.
But how about the rest of the world, for example, a lot of Asian countries? Because it's for my knowledge, it seems like in a lot of Asian countries, they have a better approach or even better supplement for women to go through those transition period as well.
Yeah, so we've got a friend of ours who works primarily in the Asian space, mainly in Malaysia. It's probably a bit of it's even more of a taboo subject in the Asian countries that, from her understanding. So it's as much about trying to get women to talk and actually go forward and ask their doctors for that. For those options, probably is the point. Where they are at from a medical point of view, we're uncertain. But if you look at Australia and what Britain is doing as well at the moment, they are definitely a step forward in what they're offering to women in this as a transition process.
So do you think that in the current market, do we have
Carlos.
enough? Sorry, Shay. Just based on the current market, do you think we got enough supplement or different things for, like, because I know that in other Asian countries, they do have a lot of products to try to help the woman to adjust their hormones level or go
Are
through
you
this
talking about natural health supplements?
There's a lot, the different, including health natural supplement as well. But also, I think for me, it's just more like based on our Western medicine strategies. Is that the right approach to target or improve the
gold
outcome?
standard is menopause hormone replacement therapy, so MHT.
Okay.
That's the gold standard treatment.
Okay, we're gonna Johanna, and then we'll close.
Thank you for presenting today. I was just looking up our GP training and the curriculum that they undertake as a part of their professional development, and they have a unit called Women's Health, of which I saw they spend about 10% of that time looking at, as women age. There's a big focus on when we're younger, and youth health and as wahine. Perhaps it is about maybe, you know, aging well is something that could have a bit more focus in terms of thinking GP because they are frontline. But do you have thoughts around also the way that nurses can be a part of that conversation and be trained to be a part of that front door to initiate conversations and build their capacity and capability alongside our GPs?
Absolutely. We know that a lot of practices now have practicing nurses that can prescribe, and a lot of them are becoming menopause specialists in their own right. So it doesn't have to be just GPs, but that's we need to start somewhere. And if we can get to the stage where GPs have a good education level and resources that can be used across the GP practices, then I think that becomes a bigger opportunity.
Thank you. Look, it was really good presentation. I think you raised a number of excellent points. Thank you as well for coming to Parliament a couple of months back and presenting them, not just a phase presentation. Very touching. There's work to do here. You actually got an extra 5 minutes.
Thank you. Oh, there you go.
Thank you very much.
Appreciate it.
for all your work in
And
this space.
you'll be hearing from us. Thank you.
Kia ora.
Cheers.
Kia ora.
Thank you very much.